Alright, so this is the shoulder flow. You do this when a person has pain to the shoulder. What is the shoulder? Pain around here. Pain over here, I'm thinking more neck, and then I'm going to do the cervical flow. Okay? So all we're going to do right now is try to replicate normal type of motion. So I take the person to the point of the pain, right? Usually flexion is a good one. You can also do this a lot of times. Horizontal abduction is quite painful, or this could be painful, but we'll do flexion, right? So with flexion, you take them to the point of pain, okay? And then from here, see I use my body to kind of stabilize things, and I roll out Dura. And you see what I do here? I extend the fingers all the way, see if it produces their shoulder pain, not tightness over here, right? And the person says no, I move on. The next thing I want to know, if the C6 is if this last is hypertonic, we come from C6. So I go to facilitate a segment. What I can do, I come around here, okay? And let's hold the whole head here and lift it up. But if you pay attention, I didn't drop down the arm, right? This is where point his pain was. I back up just a tiny bit so he's not in a lot of pain. Then lift up, see if I get more motion. If I get more motion, something's going on in the neck, right? And I have to do cervical flow, right? Next thing, I give stability. Hold the whole neck and give it just general compression. And once again, I then let go of the arm over here and see if I get more motion. Okay. If it did help, I need to do a cervical flow. Right. Next thing is, keep that over here. Right. The thoracic spine, right? With flexion, especially, you have to extend and rotate. So see how my hands are kind of pushing this direction here to facilitate an extension, right, and rotation. And I see if I get more motion. If I get more motion, then I need to figure out why he's so stiff over here. Okay. So this whole entire time, I'm just holding him over here. I'm gonna give him a little break here. Then I'm gonna clear out the thoracic, right, for instabilities, right? So you do the wiggle test, which you've probably seen in another video, where you kind of move one rib from side to side, and you see where it has a hard time moving either to the left or the right. Think of the ribs as a long transverse process attached to the spine here. And for example, Donnie has a hard time going this way to the left, so what do? I hold the whole segment and push it to the left and hold him there. We call that stacking, and have him now lift your arm up again. Okay? Make sure when you do this, you don't block scapular motion, right? Go all the way up and see if it helps with the motion. Okay? That's how I clear out instabilities. Because if you have an instability here, your muscles will work harder and therefore throw off the scapulohumeral rhythm. Okay? If you have instability in the neck, the muscles in the neck will start guarding and they'll throw off scapulohumeral rhythm. If you have positive dura, the dura hates scapular depression. Right? Stupid alarm. Pause. Stop. So, if the dura is affected, you add more dura tension with scapular depression, right? So, if a person has dura tension, then keep the shoulder height, and therefore you're messing up the shoulder mechanics. So that's why each of those things could throw off the whole entire neck. Right? Now, the next thing is the scapula. Well, with flexion, you have to know your scapulohumeral rhythm for different type of motions, but with flexion, the scapula has to depress, upwardly rotate, protract, and posterior tip. Right? I want to test all four at once because it's really painful for the patient. So you do it all at one time. So I remember my baseline. This is how far you could go, and then from here I do all four. Right? See what I do right here? I am what? Upwardly rotating, depressing, posterior tipping, okay, and protracting at the same time. Ready? And go up. Alright? And see if it gets more motion. If I get more motion, I do one motion at a time, see which one is the culprit. Okay? Same thing, go to the first rib. Okay? The first rib goes under the clavicle, but if it's elevated, it hits the clavicle and therefore affects the scapulohumeral rhythm. Okay, go up with me. and I see if that helps. Right? Alright, and the last thing, the GH itself, right? I go give it inferior mobilization. You see how I go on top of the humerus here, give it a downward glide, and then lift up again. Lift up. Right? Now, the key is give it a downward glide and let the person come up at the same time. Okay? And then the last one is give a posterior glide. Right? The reason why I don't give a posterior glide right at the GH joint, most people have bicep tendonitis, so it's going to throw them off, right? That's why I go at the humerus here at the distal end, give this posterior glide until the person lift up. And with that, it helps a whole lot. Alright? So if any type of GH stability helps, I'm like, why is the rotator cuff not doing the job? Can the rotator cuff not turn on? So what I do a very simple thing where I take it right to before the point of pain, I'm having activate the rotator cuff. Very simple command is don't let me pull your arm out. Don't. Okay? By him doing this, right? His rotator cuff is turning on. If you're not quite sure, relax. Just palpate the spine of the scapula. Palpate superior and inferior to that. Feel for the muscle. Pull. That's turning on. Okay? So I know the muscle turn on. And then keep turning on, but let me move you. Right? And now I'm trying to see, for example, that helps Donnie. So I know the rotator cuff muscles are strong, but they're not just turning on when they're supposed to, so we need some neuro re-education. If that cueing does not get the muscle, if the cueing does not help, that means I need to do a rotator cuff strengthening. Okay? Strengthening versus neuro, totally different type of protocols. Okay? So, by doing the whole assessment, you can clear out the dura, you can clear out for facilitated segment, clear for instabilities of the neck, instabilities of the thoracic spine, hypermobilities of the thoracic spine, scapula not moving properly, the first rib not moving properly, the GH joint, either the inferior gliding or the posterior glide, and you're also checking for the rotator cuff to get like 9 categories that can happen. Okay? So make sure you get practice and do one step at a time.